Hey there, everybody. My name is Dr. Mica Riley. I am here at the MoveMed Rehab and Performance headquarters in Seattle, Washington. And I'm so happy to have you guys here with me today. We have created this community for you guys that are in this ACL community, whether it's your friends, family, daughter, kid, whatever it might be. We want to just provide you with evidence-based information to help you create informed decisions on your journey to recovery, but also make sure that you are getting the best care possible because you need and you deserve it. And our goal is to help reduce the re-tear rates. And so by doing this, this is what we are aiming to do. So other thing is make sure that you go through our ACL roadmap. Our ACL roadmap basically highlights expectations and even some more information by taking a little bit deeper dive during each phase of the ACL rehab process and what to expect, and may even answer some questions that you might have currently. The other thing is if you are finding that you are lost in your ACL journey and don't know what to do, or you were just kicked off because insurance is no longer going to allow you to be seen by your physical therapist because return to sport is not medically necessary, that is what we are here for. We are ACL rehab coaches. We see many people from across the country to even across the world, and we provide remote coaching, ACL coaching specifically, to help you get back to what you love. So if you're interested in that and that resonates with you, we offer consultations to have a conversation about what you're going through and how we would do things and what we might recommend, and potentially get started working with us. So you can schedule using the consultation link to the left on the sidebar. If not, reach out to us directly. That's what we're here for. Okay, so we're going to get to the topic of LET procedure with an ACL reconstruction. The LET procedure has been around since the 1960s and was used primarily in the youth, but more recently has become more popular as research has actually found it to be a little bit more helpful in those who are at high risk of re-tearing their ACL. So the LET stands for lateral extra-articular tenodesis. That's why we say LET procedure. So, there's other augmentations or reinforcements, but the LET has been shown in the evidence to be more superior than the ALL. But we won't go through the ALL, just the LET procedure. So I want to highlight that, not everyone is a good candidate for this, and it is very dependent on somebody's situation and what their evaluation in front of the surgeon looks like. Surgeons do take different approaches to how they perform the specific procedure, so I will say it is very surgeon dependent. We won't get into the weeds of the different approaches that they take, but the gist of it is that they take a small amount of your IT band and either loop it around the LCL, the ligament on the outside that supports the knee, or they can take it through the tunnel that they drilled to help reinforce that, and then come through and basically loop it and then reinforce it back to itself by using a some sort of screw, or even like a staple. So sounds a little, it's very nitty gritty, I will say, and it's very surgeon dependent on how they're going to loop this thing through. So, but the purpose of today's topic or live webinar is to go over common issues that can be seen with an LET procedure when it's paired with an ACL reconstruction. Now, I do want to say, to help assure you, that these complications actually happen in less than 8% of the people that decide to have an ACL reconstruction and an LET procedure. So very small percentage, but with anything, just like surgery, there are risks involved with it, okay? And that's just something you acknowledge and you accept, and you cross that bridge if you have to. But in terms of the research, the failure rate of this is less than 3.6%. So it's pretty promising. Typically, I like to go over typical reasons why a surgeon will consider doing the LET procedure in conjunction with the ACL reconstruction. One of the factors that we're seeing often is that more surgeons are doing LET procedures in people who are less than 25 years old. A lot of the people who are in their youth or teenagers and are involved in those high risk sports, less than 25 years old, they will maybe be a candidate. The other thing is if somebody is planning to return to a contact pivoting sport, someone who might be very hypermobile, like having a connective tissue disorder, and we're talking hypermobility being like extreme hypermobility, like having more than 10 degrees of hyperextension, more than 20 degrees even, where they just need that extra stability. And that is a genetic issue that they just need help with, and that's something that they might do. The other thing is if you had a high grade tear or have a lot of rotational laxity, this is a test that they will perform when you are under anesthesia. And if it just gives way into rotation quite a bit, then you'd probably be a candidate. The other thing is revisions. If this is not your first ACL journey and you're on your second, your third, your fourth, your fifth, I've seen some people who've gone through 5 tears, you are a candidate for this. And I will say myself, I've gone through 3, and for my 3rd ACL reconstruction, I did decide to do the LET procedure for that reason. I just don't want to have to go through this again, and extra stability I can get right now, the better. So let's get to the meat and potatoes of all of this. So I will say right off the bat, I want to be very honest with you. I'm going to share my own experience with this as well, but the first 3 months are very difficult. Regardless, whether you have the LET procedure or not, you won't probably feel like yourself until 3 months anyways, just because that first 3 months, your responsibility is to manage the pain, the swelling, and just get back to a normal function. Okay, but typically what I have seen, and even in the experience of myself, the first 3 months after the LET procedure with an ACL reconstruction is not easy. And it doesn't mean that it all is painful or anything like that, but the things that you experience are pretty common in an LET procedure. So the first thing we're going to talk about is stiffness. This is absolutely common with the LET procedure. Stiffness in general is common in just an ACL reconstruction, but because there is extra trauma that was performed to perform the procedure, on top of if you had a meniscus repair or something like that, that's just a lot of trauma. That's a lot of tissue needing to be healed, a lot of scar tissue formation needing to be formed, and then here comes stiffness. So it is very, very common just because there's just a lot of stuff being done during your surgical procedure that requires a lot more healing later, okay? Next thing is range of motion. Range of motion, oftentimes in my career and seeing people with the LET procedure, I often see teenagers and younger people, and typically they bounce back pretty quickly. Most often I've yet to see anybody that really, really struggles with their range of motion. But oftentimes, if we do see a struggle a little bit, it will be with flexion. Okay, so basically because of the stiffness that happens and the healing that needs to happen and the swelling that might still be there, that will commonly cause some difficulty trying to achieve full flexion. Doesn't mean that you won't ever achieve it. It just means that you might take a little bit longer than somebody who didn't do the LET procedure. The other thing is there will be a range of motion restriction into extension, and this is purposely done. Because now that you have decided, or if you do decide to do an LET procedure, it's a structural block. This is intended to help block hyperextension. Now, I've seen people 2 years out of this procedure be able to achieve their full hyperextension, just because it kind of stretches a little bit over time, but not too much, but it can. But usually it's a hyperextension block. So basically you won't get maybe beyond 0 to 1 degree of hyperextension. And maybe I've seen some get 3, but those are very rare situations. But it's very rare for somebody to get beyond like 1 degree of hyperextension. And this is on purpose, because now you have a structural mechanism inside the knee that has been looped to help reinforce you from going into those significant degrees of extension. It's not, I want to highlight that hyperextension, normally we want to normalize and try to achieve whatever the other side is achieving. So I want to normalize hyperextension. It's not entirely a bad thing, but for someone who's on the extreme end of ability to tap into their extension, they might need a little bit more stability. So structurally, you won't be able to really fight for like your 5 degree hyperextension like you have on the other side. And then, as we talked, flexion is just typically slower to come back because of the excess healing required, the swelling, the pain response, all of those things too. The other thing is bruising. Bruising is very common to have. Just, think about, going into, you're basically going into a boxing match with your surgeon, but you're under anesthesia and he's just doing all the work to you. So it's, everyone's response in terms of bruising is going to be different. I had just local bruising around my knee in general. I've seen many people who've either had bruising from their butt all the way down to their foot. It just is so variable in how your body wants to heal. So very normal response to see afterwards. And sometimes even this bruising might be there for even a prolonged amount of time. Very, very subtle. You might not even be able to see it to somebody who doesn't know you have it. But I've seen some who maybe 8 to 9 months out still have a little bit of bruising. Infection. Infection is another one. It is, with any surgical procedure, there's just that risk for infection. The risk is very, very low. It's less than like 0.1%, but it can happen. And I don't want to say that it doesn't happen, but that is something, extra trauma and extra incision we have to worry about. And, that's just something we watch out for. I have yet to see someone with an infection along the LET procedure incision. But, it all depends on the person and depends on how their body wants to heal and whether it's willing to fight off whatever trauma or whatever situation wants to come about. Okay, something I have seen and also in the research that we can see is painful hardware. So in all the ACLs I have seen with an LET procedure, I've only seen one that has had difficulty with their hardware. So as we mentioned, they take the IT band, they go and loop it, and then they come and either use some sort of like screw, some sort of pin, some sort of staple, and then staple it to itself. And this can cause a little bit of friction, especially like, the person that I did see with this had a hard time going into knee bending, knee flexion, and was a little bit painful and a little uncomfortable. And so it kind of was adding that extra friction for them and just was limiting our progress and what we could do. So we sent them back, ended up being the hardware situation. And basically they got the hardware taken out and had it undone, and then they were fine after that. So very rare, but can happen. The last thing is a hernia. So, just similar to like a stomach hernia, if basically causes a little bump or a bubble. And a lot of times this has to do with because of the added pressure alongside the outside of the thigh. And this can cause the outside of the quad where it kind of blends in with the IT band called the vastus lateralis. basically to herniate or cause some sort of little tiny bump or bulge. It often, I have yet to see one, but, in the research, they mention it and it can be painful, but oftentimes it's not painful. But usually surgeons, unless it's really painful and limiting their progress or their ability to do what it is they want to do, they usually won't do anything about it unless it's a true problem, or sometimes they have to determine whether this was a structural problem where the IT band reinforcement just needs to be more reinforced. So, it seems like more of maybe a cosmetic issue for some, but it also could be a matter of needing reinforcement for others. So it just is variable. But those are typical common complications in the research that has been shown to be in less than 8% of the population that do decide to have an LET procedure. So, with anything, there's always risk, and you have to just figure out what if your surgeon has recommended it to you, you just have to figure out what your end goal is at the end of the day and whether that's something you want to do in particular. In my own experience, I had ACL reconstruction with medial and lateral meniscus repair and an LET procedure 3.5 months ago. My first 3 months were absolutely hard in terms of stiffness and range of motion restriction. I just had a lot of, with the meniscus repairs specifically as well, like a lot of swelling, a lot of tissue needing to be healed, and me needing to respect that. So that's why I was a little bit slower in terms of my range of motion. But I did have lots of swelling, which then created a lot of stiffness for me that I definitely had to work through. I do have my bouts of stiffness on a daily basis, and every ACL reconstruction client I have seen, they have stiffness too, especially if they go on a car ride for 4 hours, if they sit on a plane for 2 hours, if they sit and watch TV or read a book for 30 minutes. Every day is so variable in terms of stiffness, but that is something that you just will have to harp on in terms of addressing your range of motion and doing the work on a daily basis and making sure you're not, you're working through that stiffness, of course. In terms of extension, I have only 1 degree of hyperextension. I can try to fight for more, but I can just appreciate that there's a structural block that just won't allow me to get there. And, we really, really highlight the importance of trying to achieve the extension of what and match it to what the other side is performing. But in this case, you're structurally blocked. So you can try as hard as you want, but probably won't get any more than that, just because internally you are fixed not to go beyond a certain amount of extension. And that is all dependent on the position that your surgeon decides to reinforce you in. Typically it's between 60 to 80 degrees, but it also depends on what you need from their perspective. So I will say that occasionally on days, I work out and do my rehab 3 to 4 times a week in the weight room. And when I have very quad heavy days, which is often, sometimes the outside of my leg, my thigh, is a little sore and maybe a little uncomfortable, but not painful. And that's just basically because I'm putting stress to those tissues in that area and recruiting my quad, which then influences that incision line on the outside of my thigh a little bit too. So overall, I think it was a good choice for me because it was my basically my second revision. And I just needed that reinforcement, and I wanted to do everything possible to help prevent me from going through this again. But oftentimes in my professional experience, teenagers do really, really well with this. And I imagine it's because they're not 100% done growing like we are in our 30s and 40s. And people who are above the age of 30, I find that just have a little bit more difficult time with this, just because we have built that added stiffness throughout our years of experience of living in comparison to somebody who's maybe half our age. and still has some growing to do. So yeah, so that's it. I'm happy to share more of my experience professionally with these, or even my personal experience going through this with my own rehab. So, but those are the common complications tacked on with my experience, and I hope this was helpful to you. But things overall look very promising in the research, and from the rehab perspective, we see, some have an easier time than others, but most often we get the job done in terms of return to sport without any issues. And we don't know who's going to have a setback and who will, but we make sure we address that as we hit that crossroad. So if you have any questions, please reach out to us personally. I'm Dr. Mica Riley here at MoveMed Rehab and Performance. Or if you are, feeling lost and you want to work with an ACL coach, we are here for you. We're happy to do a consultation, 15 to 30-minute consultation, which you can schedule on the link at the sidebar on the left. And if there's any more specific content that you want to learn about or want to know more about, let us know, because this is what this community was designed to do, was to help educate you with the most up-to-date evidence. All right, it's been a pleasure. Look forward to more ACL deep dives, and we'll see you next time.